gives me great pleasure to introduce Professor SSP Warnakulasuriya, Professor and the Dean of Faculty of Nursing, University of Colombo. Professor Sudath Shirley Padmasiri Warnakulasuriya is the first ever professor in nursing. Professor Warnakulasuriya entered the nursing profession in 1987 and completed his basic nursing diploma in School of Nursing Galle, and he received his BSc nursing degree from the Open University of Sri Lanka in 1998. And he received his master's degree from University of Adelaide in 2003, and he went on to do a PhD from University of Sri Jayawardhanapura and completed his PhD in 2014. And his area of occupational health and work in ergometric led to publication of many articles in peer-reviewed journals in better understanding of mechanisms of low back pain and musculoskeletal disorders among different age groups. And Professor Warnakulasuriya currently holds the Professor of Nursing in Faculty of Nursing, University of Colombo, and the Dean of Faculty of Nursing, University of Colombo. He also working towards the International Council of Nursing as a member of Scientific Committee of establishing a changing code for ethics of nurses by International Council of Nurses. So I warmly welcome you, and please start the sessions.
Right. Basically, I need to just mention about the ground rules of this presentations. All the presenters, they will get 12 minutes for presentation. When you are completing 8 minutes, 8 minutes indicated red light, 10 minutes tap the bell for one time, and also 12 minutes tap the bell for twice. That means you have to stop. The beginning of the question and answering session is indicated by green light, and end is indicated by red lights. And also please convene this session promptly at the announced time. Each presenter will be called upon with their title. I think presenters, 4 presenters are there at the moment. I would like to welcome first presenter, first paper, Contextualization of Middle Childhood Nutrition Guideline in Sri Lanka, Situational Analysis. Presenter will be RMOK Bandara. Over to you, Bandara.
Good afternoon, everyone. First of all, thank you, everyone, for giving me this chance. And I'm Kavinda Bandara from Department of Applied Nutrition in Warnakulasuriya University of Sri Lanka. Today, I'm going to talk about my research work on contextualization of middle childhood nutrition in Sri Lanka with a situational analysis. As you all know, child malnutrition is emerging problem in Sri Lanka, especially these days. You can see it is the latest topic here. So actually, the childhood is the main life stage that humans' life associated with the growth and the healthy development. So this childhood period we can consider as 3 stages, like early childhood, middle childhood, and the pre-adolescent age. So in my research, I mainly focus on the middle childhood nutrition. And we can say the primary school children and the children in age 5 to 10 year range. So here I am, the middle childhood is actually a time of transition and marked by continued and steady growth. The nutrition directly influences on their body composition, cognitive development, activities, feeding skills, food choices, and many other factors. So the problem here is we can identify there is a dual burden of middle childhood malnutrition in world, including stunting, wasting, underweight, overweight, obesity, and hidden hunger. So my objectives were to review the nutrition status of children in age 5 to 10 years in Sri Lanka with a secondary data analysis, and to investigate mothers' knowledge, attitude, and behavior on fulfilling middle childhood nutrition requirements, and to identify the interrelationship among CAB of mothers related to the middle childhood nutrition requirements, and to review nutrition guidelines for children in age 5 to 10 years. In my methodology stage 1, I have done a secondary data analysis of existing information of children in age 5 to 10 year nutrition status in Sri Lanka. My data sources were the health and nutrition related government websites and research articles published in related to the middle childhood nutrition status. What I find here is, according to Sri Lankan context of middle childhood nutrition, you can see in my figure 1, the latest update of middle childhood malnutrition in Sri Lanka to 2021 statistics. The thinness prevalence is more significant in this male and the female children. And the stunting, overweight, and obesity also in significant levels. So in my figure 2 shows that the nutrition status in children age 6 to 10 year group, like age wise, age 6 years, 7, 8, 9, and 10 separately, and every age children had the prevalence of thinness is about the 30%. Also the overweight, obesity, and stunting, and also the anemia prevalence are also can be shown in this age group. When I go for a comparison on 2016 to 2021 statistic in according to the age 6 children and the age 10 children, we can see the wasting prevalence is more higher in both age groups, and the stunting prevalence is slightly decline, but there are fluctuations. And the most importantly, the prevalence of overweight and obesity, though low, but it shows the upward trend. And in my methodology part 2, I have done a mother's scab online survey with estimated sample of 285 mothers who have children in middle childhood. And I have used a pre-tested online questionnaire and got 287 responses, and they were analyzed through the SPSS and AMOS software. Basically, my questionnaire included 36 total questions segmented by knowledge, attitude, behavior, and socio-demographic factors. And this is, according to my results of CAB survey, this is my structural equation model, and I have got 9 latent factors, which above the Combach alpha 0.5. What I find here is, I have identified there is a significant effect of mother's attitude towards their behavior on fulfilling middle childhood nutrition requirement. And though no significant knowledge effect on the behavior, but there is a significant correlation among attitude and the knowledge. So also the socio-demographic factors like birth order of child, whether the mother have one child or more than one child, or mother's age and place of residence are also effect on the attitude and behavior relationship. And the findings revealed that the mother's level of knowledge was moderate and attitude was high as evaluated based scoring system prepared by the investigators based on the scores of the experts and the general public. The knowledge, attitude, and behaviors are scores calculated as the according to these factors. In my descriptive analysis shows that according to the my sample, majority of children take their breakfast in this COVID-19 period and nearly before the COVID-19 period. And most of them have the rice and rice flour based foods as their breakfast. And when I go their behavior and consumption pattern, majority of mothers have responded as their children have take 2 to 3 servings of vegetables per day, and the 33% of mothers have responded their children take 3-4 servings per day as the recommended level. And for fruits, majority have take 1 and 2 servings of fruits per day, but the recommended level is 2 to 3 servings per day, and 32% of children have take the 2 to 3 servings of vegetables per day. And when I talk about the nutrition guidelines, WHO and UNICEF have published several guidelines, strategies, and the policies for the middle childhood, but there is no specifically addressed nutrition and dietary related guidelines for the middle childhood. But in most of countries, they have own published and implementing guidelines for middle childhood or the primary schoolers. In Sri Lanka, Manual on School Nutrition Program and the Food and Nutrition Policy for School are implementing based on the related to the primary schoolers, and also there are segment reserved for the primary schoolers in food-based dietary guidelines also. But I wanted to say that those guidelines are not directly focused on age 5 to 10 year group and not address the general public. As conclusion, the prevalence of stunting in middle childhood children shows a slight decline from the 2016 to 2021 with fluctuations, and thickness of the wasting prevalence is more higher and more significant comparatively 20 to 30%. And the prevalence of overweight and obesity, though low, shows that upward trend. And there is a significant impact of mothers' attitude towards the behavior on nutrition of children age 5 to 10 year group. And there is a significant correlation among mothers' knowledge and attitude on fulfilling middle childhood nutrition requirements. And CAB levels show significant correlation with socio-demographic factors. And there, most importantly, there is no direct focus nutrition or dietary guidelines for children age 5 to 10 year group, or we can say the middle childhood in Sri Lanka. The limitations in my research was lack of published research based on the middle childhood nutrition in Sri Lanka, and limited resources for middle childhood nutrition or the malnutrition status statistics, and the lack of internet literacy among mothers are limitation for my CAB survey. And those are some of the reference I have followed. And my acknowledgement goes to Professor Anuma Chandrasekara, Senior Lecturer of Department of Applied Nutrition, and Professor Rupika Abeynayake from Warnakulasuriya University, and Ms. Shasha Diyapaththugama and Michelle Sahabandhu, and participant who answered the question. And thank you very much for listening to me.
Right. Ms. Bandara, very interesting presentation. I think there are two phases and you have covered. The paper is open for discussion.
From the university and the Nutrition Society. Yeah, actually, I have done this survey on COVID-19 period. So I have to use online platforms to distribute, and I have direct contact the MOH and teachers, and some of the I use direct contacts and share the Google Forum. Yeah. Actually, there was not an exclusion criteria. I used the mothers who have children age 5 to 10 years. Any mother. Yeah. No, anyone.
Thank you very much, Ms. Bandara, for that informative and timely topic that you have selected to present here. I have very few questions again regarding the data collection and all, right? So you have used secondary data and also one of the online questionnaire. So I am willing to ask you about the response rate that you got from mother. How many of the sample responded to the online questionnaire?
Actually, my expected sample was 285 mothers. According to the calculations, I used the Lanka equation for the calculation, and I got responses 287, and the response rate is somewhat low, but I reached the sample size.
How long you spend?
I used
like
2 months.
2 months to collect it. So how did you do the pre-test?
Sorry?
How did you do the pre-test?
Pre-test I used in my funnel area in my university near the funnel area, and I go the MOS and I distribute the my survey to the mothers who are in the MOH and the clinic and the others around home household.
Okay. Then did you do any comparison of their early childhood data with this middle childhood data to show any difference between the previous period and the current status, like you have shown some of these anthropometry findings and all the charts and the nutritional level as a line graph. So were there any comparisons between the same child who had a good nutrition in the early childhood and comparatively the middle childhood? Were there any comparisons you did?
Actually, no, I don't get comparison between early childhood.
Okay, thank you very much.
Thank you.
Thank you, Ms. Bandara. It's a very interesting study, and I have a few more questions and a few suggestions. So did you consider the educational level of mothers when assessing this questionnaire? Because I couldn't find any data in your abstract. Did you consider the level of education? Because level of education is a very important factor when it comes to knowledge and their practice.
Yeah, I got their education levels, and most of them are in past A levels, and it's the low levels. I mean, it's low level of mothers are in primary education. Most of them are in A levels and diploma graduates likewise. So I try to see there are any relationship with this education level, but according to the statistical analysis, I couldn't get that relationship.
Okay, so and the other thing is, so you didn't consider about their age limit. So that's you just consider about the children's age, no?
Sorry?
You consider about children's age, not about mother's age, because I don't see any mean age limits in the abstract.
No, I use the mother's age and children's age too.
Yeah, it's great if you could insert it to the abstract. So anyway, and the other thing is here there are some p-values. It's great if you could insert R values as well. Right. So anyway, thank you very much. That's all what I have.
Thank you very much.
Next presentation is paper will be on knowledge, attitude and practices on bioterrorism threats among undergraduates of KAATSU International University. The presenter is DDY Rasanjanee. Yes.
Good morning, everyone. I'm Rasanjanee from Department of Biomedical Science of KAATSU International University. Our research is on knowledge, attitudes, and practice on bioterrorism threats among undergraduates of KAATSU International University. So within this presentation, I'm going to cover all these mentioned areas. As the introduction and background of our research, bioterrorism can be defined as intentional use of any kind of microorganism or any kind of toxin derived from living organism to produce a death or a disease in human, animals, or plants. So normally the bioterrorist agents also common organisms which present in the nature, but the problem is when they use as a bioterrorist agents, terrorists will modify their virulency. That means the virulency of the organisms. Therefore, those organisms become, the organisms develop resistance to the current medication, and the rate of spread that organism in the environment get increased. Based on the rate of dissemination and the rate of mortality and also the ability of cause public panic, those bioterrorist agents have been classified into 3 groups as group A, B, and C. From these 3 groups, group A is the most highest risky group and Bacillus anthracis is an example for the organisms which belongs to group A. With the development of and the modifications of the microbiological field, the use of biological weapons has advanced significantly within the 20th century. Therefore, rapid and correct identification of those bioterrorist attacks has become a very important thing, but it's a challenging matter. So to achieve that challenge, it is an essential point to develop the knowledge on bioterrorism among the each and everyone in the society. So as a developing country, as a Sri Lanka as a developing country, if such type of bioterrorist attack occurred in Sri Lanka, it will affect to the Sri Lanka hugely in bad way, because poverty leads to ill health, and ill health in turn leads to poverty. So we believe by performing this research, we can assess and awaken the knowledge or the awareness on bioterrorism among the targeted population. So our general objective of our research was to determine the knowledge, attitude, and practice on bioterrorism threats among undergraduates of KAATSU International University. Moving to the methodology, we have done this research as a descriptive cross-sectional study. In here, the undergraduates who pursuing degrees at KIU or the KAATSU International University was the study population. In here, undergraduates who give their voluntary consent to participate in our research considered as inclusion criteria, and the participants who did not give their voluntary consent to participate in our research was considered as exclusion criteria. Then using this calculation, we have got 354 as our sample size. After getting the approval from the ethical review committee of KIU, we have started the sampling using non-probability convenience sampling method. In here, we have used pre-tested self-administrated questionnaire to collect the samples. This questionnaire was in the form of Google form, and this is created by the researchers using the standard relevant literatures. After collecting the data, we have tabulated all the data in Microsoft Excel and subjected to statistical analysis using SPSS 28 as analytical tool. And also we graded these data according to the Bloom's cutoff point. According to that, scores less than 60 was considered as poor, and scores between 60 to 79 was considered as moderate, and scores in between 80 to 100 was considered as good. Other than that, we use chi-square test to assess the association between participants' faculty with the knowledge, attitude, and practice on bioterrorism, and also assess the association of knowledge with attitudes and knowledge with practice and attitude with practice on bioterrorism. So moving to the result part, in this pie chart shows the distribution of gender among the participants. According to this pie chart, among the 240 undergraduates who give their voluntary consent to participate in our research, 167 or 69.58 were females, and 73 or 30.42% was male. The result of gender of the participants was contrast with another researchers which done in other countries, as higher male respondents were participated. So in here, this 3-bar chart shows you the data regarding how the overall knowledge levels, overall practice levels, and overall attitude levels among participants has been distributed. In bar chart 1A, it shows the distribution of overall knowledge level among the KIU undergraduates, and 1B shows distribution of overall attitude level among the participants, and 1C shows distribution of overall practice levels among the participants on bioterrorism. So according to this 3-bar chart, you all can see most of the KIU undergraduates having poor knowledge on bioterrorism, and according to 1B bar chart, can get the idea that most of the KIU undergraduate having poor attitudes on bioterrorism, and according to 1C, most of the KIU undergraduates have poor practices on bioterrorism. So when discuss about this result, the results related to attitudes on our research is similar to the research which done in 2020, and also the results related to the knowledge which in our research also similar to the research which done by Menon et al. In 2010. So when go for the associations, by these charts in tables, first table shows you the association of overall knowledge on bioterrorism with faculties. Table 2 shows the association of overall attitude on bioterrorism with faculties. And this table 3 shows the association of overall practice on bioterrorism with faculties. So according to the p-values that we have calculated, we can say there is a significant association in between the faculties. That means participants faculty with overall knowledge, overall attitudes, and overall practice on bioterrorism. So, so when we go through the overall knowledge, association of overall knowledge with overall attitudes on bioterrorism, and using table 5, association of overall attitudes with overall practice on bioterrorism, and using table 6, association of overall knowledge with overall practice on bioterrorism. In here also, the calculated p-value is less than 0.05. That means the statistical significance, which we defined as less than p-value less than 0.05. In here, all the p-values are less than 0.05. So in here also, we can say all these 3 associations are significant. That means according to this result, these knowledge, attitude, and practice are interconnected, and these are affect to each other. That means according to the result, if someone have low or the poor overall knowledge regarding bioterrorism, it will leads to having poor overall attitudes and poor overall practices on bioterrorism. So as the conclusion, we conclude that most of the KAATSU undergraduates do not have more than enough knowledge, attitude, and practice on bioterrorism to play key roles in the bioterrorist attack as a response for the bioterrorist attack or preparedness for the bioterrorist attack. So we recommended to set some educational programs related to bioterrorism and set some bioterrorism preparedness training programs among the KAATSU undergraduates, because our target population is KAATSU. Other than that, it's better to educate citizens about bioterrorism using mass media such as television and radio, or using any other social media platform. And finally, further studies are needed to confirm our findings and give an insight into the responses of the awareness of bioterrorism threats among undergraduates. So these are some references that we have used to prepare this presentation. So my acknowledgement goes to our main supervisor, Professor Janani Kottahachchi, and the internal supervisor, Mrs. Yashoda Nandapala, and all KAATSU undergraduates who participate to our research, and to the reviewers of KDU who guided us, and to the KDU for giving this nice, wonderful opportunity for us. Thank you all for your listening and paying concentration for me.
Mr. Rasanjanee, very interesting. I have a simple question. Is there any bioterrorist attack or something in the history in Sri Lanka, or just too nice to know that?
According to the details, at the moment, until now, there wasn't any bioterrorist attack in Sri Lanka, sir. But we think...
Do you learn this bioterrorism things in your degree program?
Yeah, sir.
That is the reason you have selected.
Yes, sir.
Right. The paper is open for discussion.
Thank you for your nice presentation. Well, I thought this would have gone into Defense and Strategic Department for the presentation, which actually in the military, there's a discipline called CBRN. When we studied it, was NBC, Nuclear, Biological and Chemical Warfare. Now it is CBRN, that is chemical, biological, radiological, and N is nuclear warfare. So I do not know how much of literature review you have done for this. The ample literature is available. You should have quoted some of the examples in the world, although it was not prevalent in Sri Lanka. And talk more about the subject matter, even for this discipline, would have been better than the management areas of attitudes, knowledge and practice or training. It would have been much better. But however it is, it looks nice. So elaborate on the same subject and do a extensive research. Thank you so much.
Thank you, sir.
Thank you, Mr. Sanjali. I just want to know what are the questions you included in this questionnaire?
In there, madam, within our questionnaire, there are 4 parts. First part is other regarding to the socio-demographic factors.
Yes.
Then the second part to assess the knowledge regarding bioterrorism.
So
And,
what sort of
yeah,
questions did you include
such
there?
as what is bioterrorism? As they know, we have given some answers. First one is, have you heard about the term bioterrorism? Then what are the agents of bioterrorism? What are the agents that can be used as bioterrorism? Then how these bioterrorism agents can be spread all over the environment? Those are the some questions in knowledge section. And in the attitudes, we are mainly targeted about the preparedness thing. In there, we ask whether they are willing to participate any conference or any program regarding the preparedness on bioterrorism, and how they will act, or what are the attitudes towards them if there is any bioterrorism attack, and how they are going to respond in such a situation. And the practice session also mainly target about the preparedness. So we have asked what are the options for the preparedness in the bioterrorist attacks, and what are the things that we need to be ready when if there is any bioterrorist attacks, and who are the persons that should be informed if there is any bioterrorist attacks. Those are some questions,
Okay.
madam.
Thank you. How did you set the cutoff values?
According to Bloom's cutoff points, madam. So the scores less than 60 we considered as poor, 60 to 79 considered as moderate, and in between 80 to 100 considered as good.
Thank you. Thank you. very
Thank you, madam.
One question to you, Ms. Rasanjanee. I noticed that in the abstract you mentioned that there is a significant association between the knowledge, attitude and practices and the faculties, right? So I'm interested to know which faculty you have had the higher knowledge among them. Still, if you say they don't have good knowledge, still looking at your data, which faculty you identified having some of the levels higher comparative?
Yes, madam. According to our data, the Faculty of Health Sciences are the ones who have somewhat higher knowledge on bioterrorism compared to the non-health science faculties, madam.
Okay, thank you very much.
Okay, madam.
Thank you, Mr. Sanjali. One of another interesting study. And I have one suggestion, sort of question. In future, if you are planning, when you are planning this type of study, be wise, please try to expand the research at least for the universities without focusing one university. You know that you are especially here mentioning about KAATSU. When you are trying to generalize it to the general public, it will be very complicated to generalize your findings. So my suggestion is, when you are planning future studies, at least try to expand your data collection for few other universities. Then it will be very easy for you to tell something to the society, right? So thank you.
Thank you, sir.
Right. Thank you very much, Mr. Rasanjanee again. We'll go to the next paper. Relationship between emotional intelligence and academic performance among final year health sciences student in Faculty of Allied Health Sciences, General C. John Kotelawala Defense University, Sri Lanka. Presenter is RBKS Rathnagoda.
Good afternoon, everyone. I'm Kokila Rathnagoda from Department of Nursing and Midwifery, Faculty of Allied Health Sciences, General Sochon Kotelawala Defense University. Today, I'm going to present research findings under the title Relationship between Emotional Intelligence and Academic Performances among final year health sciences students in Faculty of Allied Health Sciences, Kotelawala Defense University. Content of our presentation include introduction, objectives, methodology, results, conclusion, recommendation, references, and acknowledgement. First of all, I would like to explain what the emotional intelligence is. It is the ability to track one's own feelings and emotions, to differentiate among them, and to use this knowledge to direct one's thought and action. And also it has been described the ability to recognize individuals' own and others' feeling to inspire themselves and to manage emotions effectively in themselves and in their relationships. Importance of the study regarding this area, because the previous researchers have not dealt with the same concern among healthcare students, expect medical students within the Sri Lankan context, and therefore this research will give a new contribution to the available literature in this area of this research. These are the objectives of our presentation. General objective is to assess the relationship between EI and academic performances among final year health sciences students in Faculty of Allied Health Sciences, Kotelawala Defence University. There were two specific objectives. The first one is to investigate the association between socio-demographic data and EI among the final year health science students. To investigate, another one is to investigate the relationship between EI and academic performance among final year health science students in Faculty of Allied Health Science, KDU. These are the methodology. Our research is a descriptive cross-sectional study, and the sample is all the final year students who studied in Faculty of Allied Health Sciences, Kotelawala Defence University. The total sample size is 141. The ethical approval for the study was obtained from the Ethical Review Committee, Faculty of Medicine of General Research on Kotelawala Defence University. We collect data after getting the ethical approval. Permission was taken from the Dean of the Faculty of Allied Health Science and respective head of the departments in all 5 departments to collect data from the final year health science students, and the information sheet, consent form, and the questionnaire were distributed through the Google Forms. EI was collected through the validated genus EI inventory consists questionnaire. To examine the academic performances, the students' grade point average was considered. GPA of the students was requested from the Assistant Registrar, Kotelawala Defence University. We analyzed data by using a statistical package for social sciences version 21. We used a Spearman correlation test, Mann-Whitney test, and Kruskal-Wallis test. These are the results from our research. The response rate of the participant was 95.27% out of 148 of the total sample. Median total EI score of the female was 102.5. The males median score of the sample 102. The p-value was 0.738. The table 2 shows comparison of emotional intelligence score between different demographic variables. This is the summary of the above table. Having siblings, family type, loss of parents, or participation in extracurricular activities was not associated with total EI score. Parental and also parental education qualification level, monthly income also were not significant with the EI among this group. Next, the table 3 shows the comparison of emotional intelligence score between departments. When considering the subscale, EI score for the subscale only, EAO was significantly different among all 5 departments. Table number 4 shows correlation between GPA and the total emotional intelligence. According to the results, there was a positive correlation between GPA of the students and the total EI. Table number 5 shows correlation between GPA and the emotional intelligence among 5 departments. Result shows a strong positive correlation between the total emotional intelligence among the 5 departments. These are the conclusion of our research. EI was not associated with the factors such as residence, having siblings, monthly income, level of education of father, level of education of mother, family type, relationship with mother, relationship with father, having acute illness, having chronic illness, and extracurricular activities. There was a significant positive correlation between emotional intelligence and GPA of the final year Allied Health Sciences undergraduates in Kotelawala Defense University. These are the recommendations. It is recommended to conduct longitudinal studies to investigate the relationship between EI, academic performance, and associated factors. Further, it is strongly recommended to study impact of the EI on a student's clinical practice. It was identified that having a higher EI is supportive for the students to have higher level of academic performances. Therefore, it is recommended the higher educational authorities in the country to introduce new programs, undergraduate programs for the students to improve their emotional intelligence. It will be supportive to improve the academic performances of allied health science students. These are the references of our study. I would like to thank all the students who participate in the study and all other who have support and for their contribution to our study. Thank you for listening.
Right. Thank you, Ms. Rathnagoda. That is also very interesting topic that is very educationally related study. Before giving to the audience, I have a simple question. Because according to your result, all the 5 departments, they have rated high emotional intelligence, as well as there's a very strong positive relationship between emotional intelligence and the work performance, GPA. What might be the reason in the Kotelawala Defense University, all the badges, all the final years have the same trend? Is there a specific reason? What do you think?
I think the same age group of the participants that,
Okay, you think?
the set course.
No, no, yeah, you can have any idea, but I just wanted to know that how do you think about this kind of result, right? Paper is open for the discussion.
Thank you, Ms. Rathnagoda. I just want to know, how did you define academic performance in your study?
According to the GPA, madam, can calculated until overall GPA calculated until the third year.
And did you get the permission to see it from the result examination
Yes, madam.
department?
Register, KDU register, assistant register.
Thank you.
Thank you for the interesting presentation. I have a simple question. Was there any special reason for you to select only the final year students assessing their emotional intelligence?
Yes, madam. That is the reason for GPA to take GPA.
Having all the GPA.
Yes, madam. Until the overall calculated GPA until the third year. Other students not calculated GPA. That is the reason.
Yes. Then one suggestion I have here to add something into the abstract when you write the future abstracts, right? So maybe you have this non-parametric data analysis.
Yes.
So in some areas, we notice that you have included the numbers, the statistical numbers, but in some results, we don't find it. So better you have a uniformity when you write the abstracts in future.
Okay, madam.
Just
We'll
a suggestion.
consider.
Okay.
Thank you.
Yeah, I also have a same suggestion because we can see some statistics values here. But anyway, the study is very important and very good. Is that question validated for Sri Lankan setup? You have mentioned validated.
Yes,
So
yes.
Sri Lankan setup is validated.
Yes, yes.
All right. Okay. Thank you.
Thank you.
Rathnagoda, thank you so much. Right, we will go to the next presenter. Next paper is on exploration of support needs of the newly recruited undergraduate of the Faculty of Allied Health Sciences, General C. John Kotelawala Defence University, Sri Lanka. Presenter is UPAB Nisansala.
Good afternoon, dear madam, sir, and colleagues. I'm UPAB Nisansala from Department of Nursing and Midwifery, KDU. Today, my presentation based on our final year group research project on exploration of the support needs of newly recruited undergraduates of the Faculty of Allied Health Sciences, General Sir John Kotelawala Defence University, Sri Lanka. Existing evidence report, starting university education is a transition period for youth. Fresh students may face many challenges when adjusting to the university life. Such challenges may include stay away from home and university culture, academic workload, and adjustment issues in a short period of time. These challenges can be stressful and may need support and guidance from academic level and personal level. And in addition, such challenges may aggravate crisis period like COVID-19 pandemic. Therefore, we intended to explore the support needs of newly recruited undergraduates of FAHS KDU during the COVID-19 pandemic. We use a descriptive qualitative research approach to our research study, and we conduct our research study among the first year undergraduates of all departments. Altogether, we have 5 degree courses at FAHS KDU. We include all the freshly recruited undergraduates of our faculty who gave consent to participate our research study voluntarily, and we exclude the student who did not give their informed consent to participate our research study. Yeah. We selected participants using a purposive sampling method, and altogether we invited 34 students to fulfill our saturation point. We gathered data from semi-structured interviews and short interviewer-administered questionnaire to collect socio-demographic information. When moved to the data analysis, quantitative data, mainly socio-demographic information, analyzed using simple descriptive statistic, and qualitative data analyzed using Brown and Clark 6-step thematic analytic methods. Now I'm moving to the findings of our research study. According to our findings, all of the participants were age range of 20 to 24 years, and among the 34 students, 25%, mean majority were females, and majority of students from nuclear families. And among them, 47% were from Western province. In addition, there were also students from faraway places like Anuradhapura and Kandy. A majority of participants mentioned that their monthly family income is above 75,000 rupees. When performed thematic analysis, we came across 6 themes, and I will explain one by one. Our first theme was adjustability. Simply, the adjustability means the concerns of students regarding the support they require during the transition from school life to university life. Many students reported that it was difficult for adjust to the online lectures because online teaching method is a very new concept for Sri Lankan students. In addition, some reported that they face some difficulties to adjust to the university culture after reopening of the university. Some reported difficulties in following online lectures due to their poor English knowledge, because most of Sri Lankan students take their primary and secondary education in Sinhalese medium, but when moved to the university education, it become English medium. So the following lecture is a really problem for the students. And some of students reported that they were reluctant to ask questions, even though that they couldn't understand the lectures. And speed delivery of lectures and unfamiliarity with technical terms and poor explanation also generate challenges for the students. Our theme number 2 is unmet academic support needs. No direct contact with academic members generate many challenges for the student. As example, one student mentioned that we had no idea who our lecturers were, and we didn't even see some of them during the lectures. So we were hesitant to discuss our concerns with them. In addition, some students reported that they did not have laptops or computers at home, and even though some have connection problems, and which cause poor attendance and missing of important lectures, other lectures also. And other unmet academic support need is not physical access to the library. So they were reluctant to read ebooks also. They mentioned that if they have a physical access to library, will increase their textbook reading rate. Our theme number 3 is complicated student enrollment. Due to the COVID-19 pandemic, the student recruitment process was delayed, and in addition, there were multiple enrollments. So the student who joined late had to deal with heavy workload in compared to first batch students that also their support need. Here I mentioned some statement that we extract from the interviews that I mentioned here. Our theme number 4 is family support. In here, there are both positive and negative concerns toward family support. Learning from home was joyful and easy for those who receive encouragement from family members and enough privacy to attend lectures. attend lectures. However, some students reported as follow: my mom brings me tea during the lectures and appear on the screen. Or when I unmute to answer a question or ask a question, others hear people talking. It was really embarrassing. So our theme number 5 is financial needs. Some students mentioned that financial difficulties of buying computers and purchasing recurrent data cards for participate online lectures as a challenge because they are still a dependent. And however, some reported that they were able to save money during online lectures because they don't have cost for traveling, boarding or hostel fee. In addition, additional foods expenses can be saved. Our psychological support needs is our theme number 6. We identify psychological support needs include measures to improve emotional well-being, academic support, and interpersonal skills. Even though support was available at the faculty level, most of students were not aware about the available support services. As example, the counseling program and the personal tutors like thing. In addition, most of the students complain that heavy workload also become a psychological burden for them. Here some special statement that I mentioned here in our presentation. And while we conduct our research study, there are also few limitations. These results only from Faculty of Allied Health Sciences. Therefore, we cannot generalize the findings to the entire university. Finally, our conclusion is newly recruited students have experienced more challenges caused by the COVID-19 pandemic, and their support needs have not met during the first year. Our recommendation is it is important to have plans to address such situations in the future. Here are some of our references, and I would like to acknowledge all the participants and the supervisors and co-supervisors. Thank you all.
Right. Thank you very much, Ms. Nisansala. It's a timely, important, and also timely relevant study, qualitative study. Paper is open for discussion.
Thank you, Ms. Nisansala. Do you want to explore of supportive needs of newly recruited undergraduates during the COVID-19 pandemic?
Yeah, we try to explore because
so yes, you want to know the supportive needs for the first year students during the COVID-19 pandemic. So I would like to suggest you have to change the title. You didn't mention anything about during the COVID-19 pandemic in your study title, isn't it? And the second thing is, I have noticed that in the abstract, you said you did in-depth interviews, semi-structured interviews. Which one you used?
Both semi-structured interviews and short interview administered questionnaire.
That is two different things. Right? In-depth interviews and semi-structured interviews are two different things. So better to say, I think you did semi-structured interviews, not in-depth interviews. Isn't it?
Semi-structured interviews.
Yes. And how did you select? I mean, you said you used 34 first-year undergraduates.
Yeah.
So just recruited, or what was their duration in the first year? 3 months, 6 months, or 1 year?
1 year.
1 year. So during whole time they use to learn via online.
No. Sometimes after reopening period also there, but while we conduct the research study, they was learning from home.
And you did your interviews over the phone?
Online
interviews. No. How did you conduct your semi-structured interviews? Face-to-face or online?
Online.
So you better to mention those things in the abstract. And if I ask, how did you achieve data saturation?
While we conduct the interviews, again and after some point, again and again, we receive same information from the participants. So we assume that the saturation point is we achieve.
Thank you. Thank you.
Thank you for the interesting presentation. I have one question to you. This is regarding after the study, whether you had any students for reference and for academic support and anything from the sample that you had in the study. So within the sample, if you have had identified some of the problems, whether you referred them for any support or what type of interventions you did after the study.
When we identify a problem, we talk about our co-supervisors and supervisors. After that, they refer that students to the lecturer when academic problem is identified. If a psychological problem is identified, they refer to the mentors.
Okay. Thank you.
Thank you. It's another good study. Did you use any software for data analysis? So can you briefly explain me about data analysis method that you have done?
And Clark 6-step thematic analytic methods.
Okay.
To socio-demographic information analytic, we use SPSS, and the qualitative data analyze using Brown and Clark 6-step thematic analytic method.
Right. Okay, right. Then you recorded the discussion, isn't it?
Yeah.
So how did you transcribe? Then transcribe, then make themes?
Yeah. Several times we listen to the audio recordings.
Okay.
Then we all transcribe into papers. Then again and again we read to get familiarized to the data.
Okay. Right. Good.
Go to the final paper. This paper is on barriers to implement evidence-based practice in intrapartum care and exploratory descriptive qualitative study. The presenter is online for the question and answering session, but video recorded video will be played. Thereafter, we will go to the question and answer session.
Hello everyone, I'm Diyapaththugama from University of Peradeniya. I'm here to present my study findings on the topic of barriers to implement evidence-based practice in intrapartum care and exploratory descriptive qualitative study. And this is the outline of my presentation today. Improving maternal and neonatal health remains a global challenge. Improving the quality of intrapartum care is one of the most critical challenges to achieve the Sustainable Development Goals. Evidence-based practice is an effective approach to improve the quality of intrapartum care, and appropriate adherence of healthcare professionals to the evidence-based practice is very important as it directly affects the quality of patient care. Therefore, exploring the barriers to implement evidence-based intrapartum care is crucial to deliver high-quality care to laboring women. The objective of this study was to explore the barriers to implement evidence-based practice in intrapartum care at the delivery room of Teaching Hospital, Peradeniya, Sri Lanka. Moving on to the methodology part, this is an exploratory descriptive qualitative study which was conducted at delivery room of Teaching Hospital, Peradeniya among obstetric care providers in the labor room. 17 participants were included in the sample using purposive sampling. Obstetric care providers with a clinical working experience of at least 1 year and the desire to express their perspectives were included in the study sample. An interview guide was developed after a literature survey and further refined with expert opinion, and it was used as the data collection tool. Initially, informed written consent was obtained from each participant, and individual semi-structured in-depth interviews were conducted by the principal investigator. The interview duration lasted between 40 minutes to 105 minutes, and the interviews were tape recorded with their permission. 17 interviews were conducted until the data saturation point. In data analysis, recordings were transcribed verbatim in sync color. Then 2 researchers, including the principal investigator, independently reviewed the transcripts to identify the initial codes. Then both researchers jointly discussed and finalized the primary code list. The 6 steps described by Brown and Clark was followed during thematic analysis. The ethical approval for the study was obtained from the Ethics Review Committee of Faculty of Medicine, University of Peradeniya, and the permission to collect data was obtained from the Director of Teaching Hospital, Peradeniya. Moving on to the results part, 69 primary codes and 13 sub-themes and 3 major themes were emerged during thematic analysis. Major themes are barriers related to care providers, barriers related to organizational environment, and barriers related to laboring women. 5 sub-themes were emerged under barriers related to care providers, then 6 sub-themes were emerged under barriers related to organizational environment, and 2 sub-themes were emerged under barriers related to laboring women. Shortage of staff was the first emerged barrier in the discussions with healthcare providers. A midwife stated, there is a huge staff shortage. For example, 5 beds are allocated for 1 midwife in the cubicle number 3. Sometimes all the 5 beds are occupied by the mothers, so that 1 midwife has to receive all 5 mothers, and everything should be done to all 5 mothers by 1 single midwife. Sometimes 2 deliveries happen at the same time, so she fails to attend both deliveries at once. Another barrier emerged was poor attitudes of care providers. The maternity care providers should have a positive attitude towards peer workers, laboring women, and the care they render to these women. The nurse manager explained her experiences of intervening to resolve conflicts among care provider groups. The staff is divided into different groups. Some nurses think that this is not my duty, this should be done by a midwife. Then midwives think that why I should do this is not my thing. At that times, I intervene and explain them that this is a teamwork and the effect goes to the patient. Another sub-theme emerged was poor relationship among care providers. The poor relationship between care provider groups interfere with the quality of care provided to women and the overall atmosphere of the delivery room. A midwife emphasized the lack of mutual support between care provider groups. Most of the times, the minor staff members are not there to support us, at least to get help to hold mother's legs. Sometimes there is no any staff member around the delivery to support us. Even to provide a dustbin or to switch on a spotlight, we have to get everything done by ourselves. Another sub-theme emerged was poor relationship between mother and care providers. The nature of the relationship between women and care providers was ineffective in terms of communication and interaction patterns. Many care providers focus only on performing certain tasks on women without having any direct verbal communication with them. A midwife quoted, "Sometimes we haven't talked to some mothers until they deliver their baby. Either we were busy or we have missed to talk, but I think we need to communicate throughout with them from the beginning." Another sub-theme emerged was lack of care providers' knowledge about evidence-based practice in childbirth care. The care providers' knowledge gaps of evidence-based intrapartum care has led to unnecessary obstetric interventions in the labor room. An obstetric physician emphasized the care providers' lack of awareness on evidence-based guidelines. I think the awareness of the staff about updated guidelines is not sufficient. The issues arises when the guidelines are not followed. For example, the midwives don't have a clear idea about the CTG guidelines. So when a deceleration of less than 15 seconds appears at CTG, they quickly inform the HO and omit the syntocinon infusion. So the labor no longer progresses. This is so common in our labor room, and it leads to increase the number of unnecessary cesarean sections as well. Under barriers related to organizational environment, the sub-theme emerged was gaps in administration. This concept includes lack of proper supervision, lack of support from hospital administration, and lack of appreciation of the service. A nurse midwife declared, "Consultants do not often visit the labor room. Supervision is really inadequate here. An adequate supervision always enhances proper care, because if someone supervises us, we will be motivated to work and we will not do wrong practices. But no one supervises our work here or tell whether we are doing wrong." Another sub-theme emerged was high workload in the labor room. The healthcare providers reported that their heavy workload as a major constraint to the provision of high-quality care. A midwife declared, "When the patient load increases here, our workload also increases. So we rush and do the work without considering much of the quality. During busy times, we only focus on completing our tasks rather than providing patient care. When we are busy, it is really unfair to mother." Another barrier emerged was lack of physical resources. From the care providers' perspectives, lack of physical resources and infrastructure was perceived as a barrier to deliver proper intrapartum care. A midwife stated, "We don't have enough beds. Sometimes we have to transfer postpartum mothers to trolleys in order to give a bed to a new mother." A nurse midwife also described that the delivery instruments are not functioning properly. Episiotomy scissors and cord scissors do not cut properly. We really face difficulties during the episiotomy as the scissors are blunt. Another sub-theme emerged was lack of training. Majority emphasize the importance of having in-service trainings to update their knowledge and skills on current trends in intrapartum care. A nurse midwife stated, yes, we are lacking in-service trainings. All three groups need in-service trainings. The common knowledge we gain from those trainings is really worth, but currently we do not receive such in-service trainings. Another sub-theme emerged was lack of use or availability of updated guidelines. Care providers identified lack of availability and use of updated guidelines as one of the barriers to improve intrapartum care. The nurse manager emphasized, as midwives, we do not refer any specific guideline at labor room during our practice. The patient management is totally based on the consultant's plan. Other than that, we do not have any recent updated guidelines at the labor room to refer. Another sub-theme emerged was drawbacks in implementation of intrapartum practices. Some care providers have identified several drawbacks in implementation of evidence-based practice in childbirth care. The nurse manager stated the identified barriers to implement labor companionship. Labor companions don't like to wait too long inside the labor room. They get bored with time. And sometimes mothers also refuse to have a labor companion due to privacy issues. Similarly, a physician also pointed out that some best intrapartum practices are not really practically implemented in the labor room. I have read about labor companionship and that the mothers can be given a snack during labor. I have read these things, but we practically do not do these things here. Under the major theme number 3, barriers related to laboring women, the sub-theme emerged was lack of maternal knowledge on childbirth and labor room procedures. Lack of prior awareness of women on childbirth and labor room procedures was identified as barriers to provide proper intrapartum care. A midwife stated, most of the times, mothers think the baby should be delivered as soon as they are admitted to the labor room. They don't understand that the cervix should be dilated to 10 centimeters and that they have to be in the labor room for this much of time. Another sub-theme emerged was lack of maternal support during labor and childbirth. Some laboring women are uncooperative and do not support to labor and childbirth, which eventually causes both maternal and neonatal complications. A nurse midwife declared, some mothers are really very uncooperative, never listen to what we say, so it badly affects on the delivery. Usually tears occur during episiotomy in those mothers, and they do not push when the time comes, so the baby doesn't cry when born. Hence, both mother and the baby may have complications following birth. Moving on to the discussion, Wickremasinghe et al. Reported lack of physical and human resources, lack of motivation to change practice, poor relationship between mother and care providers and among care providers as barriers to adopt evidence-based practice in intrapartum care in line with our findings. Similarly, Turan et al. And Belzan et al. Also reported negative attitudes towards changes in practice and lack of skills in performing new practices as challenges to adopt evidence-based practice in intrapartum care. In our study, lack of supervision and appreciation were identified as the drawbacks in administration. Similarly, poor motivation, poor compensation, lack of supervision and professional support were also reported in several studies. Few studies identified work-related burnout, poor working conditions, and lack of essential medicines and supplies as barriers in line with our study findings. In current study, low awareness of laboring women of childbirth and care options was an important barrier. Increasing women's awareness about care options is a good strategy to sensitize women and increase effective communication between care providers and women. It will also encourage the women to participate in decision-making about their care. Lack of maternal support was another major barrier raised during intrapartum care. That may be because of less pain tolerance and fear and anxiety about their impending childbirth in a new environment. In conclusion, the current study identified a number of contemporary barriers for the implementation of EBP in intrapartum care. However, the adoption of evidence-based intrapartum care is a complex process with many challenges in everyday implementation. Therefore, effective strategies should be determined through a participatory approach to encourage the care providers to efficient adoption of evidence-based intrapartum care. Also, developing national policies and the quality assurance systems will contribute to the reduction of unnecessary obstetric interventions and emphasize on the needs and preferences of women during childbirth. These are the references which I have used to prepare the presentation. University Research Grant 2019 is acknowledged. Thank you.
Muted, Ms. Wickremasinghe.
Hello, sir. Am I audible to you?
Yes, we can hear you. Right, Ms. Wickremasinghe, the audience listened to your presentation, very interesting. It's a qualitative study related to maternal care. The audience is expecting to ask some question. The paper is open for the discussion. You can answer the question, but
Hello, Ms. Wickremasinghe, can you hear me?
Yes, madam.
Thank you very much for your presentation. And do you think evidence-based practice knowledge or knowledge regarding evidence-based practice is same among doctors, nurses, midwives? Do you think it's same?
No, madam.
Then
It totally depends on. Am I audible to you, madam?
yes, please. Yes, go ahead.
Yes, madam. I think it differs, madam. It is based on the knowledge that they gain from, the updated knowledge, madam. Time to time, different updated knowledge comes as guidelines. So it depends on how they receive those updated knowledge.
So how you can pool their interview data into one team, because their experience, their training, the knowledge they have is different. You didn't use homogeneity sample for your research. Can you understand that?
Sorry, madam.
Did you didn't use homogeneity sample in your study, and you also know their knowledge, experience regarding evidence-based practice is not the same.
Yes, madam. Knowledge, receiving updated knowledge is one aspect, madam. It's one kind of a barrier, and there were other barriers which affected on the adoption of evidence-based practice or evidence-based intrapartum care, which are common for those several groups.
Do you think like that, isn't it?
Yes, madam, there are some common barriers.
But you focus on evidence-based practice, and you use non-homogeneity sample as well. And what type of data collection method you use? In your abstract, you said face-to-face, semi-structured, in-depth interviews. Which one?
Yes, madam. Individual in-depth interviews, madam.
Then why did you say semi-structured interviews?
Madam, the interview guide that I developed is semi-structured. That's why.
So via semi-structured interview guide, you did in-depth interview.
Yes. Yes, madam.
And one more suggestion, go back and see your experts, right? You said a nurse midwife declared, and then you include your excerpt there. And at the end of the excerpt, you said SCW1, SCW17, SCW13, like that. HCW is healthcare worker.
Healthcare worker. Yes.
Midwife, not a nurse.
Okay. Okay, madam.
Did you realize that?
Yes, madam. Thank you.
Thank you.
right, Ms. Wickremasinghe, again, thank you very much for making this interesting presentation. There are no more questions.
Thank you, sir.
Right. Okay, now we have come to the end of the presentation. That means end of the session. Session number 3, take place session 3, nursing and midwifery. I feel that it's very interesting and also very positive session, because there are different positive factors Shall I? Yeah. Because there are different topics they have covered in this session, especially when you come to bioterrorism, it's a completely different area. Then emotional intelligence, one of the most important area in education. Again, timely important qualitative research has been done. Again, parts when you come to the last presentation, also very interesting in qualitative study. And also all the presenters got wonderful question and answer session, several questions raised by the audience and also perfectly answered by the participant, very actively participated. All are very good point in this session. And also we have come to the end of this presentation. I think all the judges and other participants actively engaged. Thank you very much for all the participants and as well as the audience who actively participated, and also all the presenters. Well done. Thank you very much.
Thank you, sir. Ladies and gentlemen, we have now come to the end of the technical session of nursing and midwifery. Before concluding the session, I would like to invite the chairperson, Professor SSP Warnakulasuriya, to award the certificates to the presenters as a token of appreciation. First, I invite Ms. RMOK Bandara. Ms. DDY Rasanjanee. Ms. RBKS Rathnagoda. Ms. UPAB Nizansala. Thank you, sir. Please remain on the stage to present the mementos to the panel of judges as a token of appreciation. First, I would like to invite Dr. AATD Chandrasekara, Senior Lecturer, Department of Nursing and Midwifery, Faculty of Allied Health Sciences, University of Sri Jayawardhanapura. Then I would like to invite Dr. DVSS, Senior Lecturer, Grade 2, Department of Nursing and Midwifery, Faculty of Allied Health Sciences, General Sir John Kotelawala Defense University. Finally, I would like to invite Dr. HMP Herath, Senior Lecturer, Grade 2, Department of Nursing and Midwifery, Faculty of Allied Health Sciences, General Sir John Kotelawala Defense University. Thank you, sir. Could you please remain on the stage, sir? I would like to invite on stage Surgeon Captain Dr. Ranga Pereira, the Dean, Faculty of Allied Health Sciences, General Sir John Kotelawala Defense University, to present the memento as a token of appreciation to the chairperson of this session, Professor SSP Warnakulasuriya, Dean, Faculty of Nursing, University of Colombo, Sri Lanka, for his participation and invaluable cooperation. Thank you, sir. On behalf of the organizing committee, I would like to express my sincere gratitude to the chairperson for his invaluable participation and cooperation. Also, I'd like to forward our gratitude to the panel of judges and all the presenters who presented their interesting research work to make this session a success. Just as importantly, I would like to thank the audience for your participation and encouragement for this session. With that, we conclude the technical session of Nursing and Midwifery, 15th International Research Conference of General Surgeon Kotelawala Defense University 2022. And we would like to invite you all for the refreshments. Thank you. Have a nice day.